everyone. Today in this video, we'll be discussing about neonatal COVID. In this video, although I will not be covering everything about neonatal COVID, but I will try to answer some of the controversies which are surrounding neonatal COVID-19. Despite the whole world fighting against this dreaded virus for past 6 months, we have still more questions than answers. In this presentation, over like 30 to 40 minutes, I will try to answer 7 controversial aspects of neonatal care related to COVID. We'll start with the antenatal period, about the safety of steroids and magnesium sulfate, whether there is a possibility of vertical transmission, which is the best mode of the delivery, what are the various tests which are available, and is breast milk safe for babies born to COVID-19, and if at all they are symptomatic, what is the type of respiratory support they need, and finally, when should we discharge such babies from our NICUs and nursery. As of today, the dreaded virus has almost caused around 7 lakh deaths around the world. The rate of infectivity, that is the babies who are born to COVID positive mothers, test positive in around 4 to 8%, and at least quarter of them, that's around 20 to 30%, require admission, the main cause being for prematurity. Respiratory support usually is required only in a small number of patients, ranging from 1 to 16%. The good thing about neonatal COVID is that the mortality remains low, to the tune of less than 1%. Till now, we mostly used to rely on case reports and case series, but lately there have been several observational studies coming up from different parts of the globe. And now we have enough data to answer some of the questions related to the perinatal COVID. The rate of cesarean section in COVID positive mothers ranges from 45 to 60%, with the rate of preterm birth being roughly about 18 to 25%. The positivity rate in units ranges from 4 to 6%, and vertical transmission has been limited to case reports and case series. When we do universal screening for mothers, it depends on the area, province, country as to which stage of transmission your province is. But it should be realized that universal screening for mothers is of paramount importance. It is not only important for mothers, but it is also important for the safety of the neonate as well as the healthcare workers who take care of the mothers and their babies. One should also remember that majority of the positive mothers will be asymptomatic. Therefore, unless we test them, we will not pick them up. According to Indian data, the symptoms vary from 1 to 30% depending on the type of unit you are running, whether it is a referral center or other. The good thing is that only 1 to 2% of COVID positive mothers require intensive care unit, and the mortality remains to be low to the tune of 0.1 to 0.2%. The first controversy is regarding antenatal steroids. We know from our past knowledge that antenatal steroids, when given for preterm birth, they decrease both mortality as well as morbidity like respiratory distress syndrome, IVH, necrotizing enterocolitis, need for mechanical ventilation, and sepsis, which is the most common cause of mortality in neonates. So what is the controversy? Why are we afraid of giving antenatal steroids in COVID positive mothers? It's because of the observational studies done in the past during the era of MERS and SARS viruses. It was observed in these observational studies that the people who received steroids There were higher mortality rates in those people, and there was increased secondary infection rate. Also, they had delayed viral clearance. Now we know that the COVID-19 may be associated with increased incidence of preterm birth. Now, before making any judgment, we should take certain things into consideration. In these studies, the dose of steroids which was used was around 200 milligrams per day of hydrocortisone equivalent. Now, some may argue that steroids are used for treating COVID-19 patients, so how can they be harmful? That's true. The dose which is recommended for treating COVID-19 patients, be it methylprednisolone or dexamethasone, ranges from 125 to 50 milligram. Now, what is the dose we use in antenatal? We use for antenatal corticosteroids. It is around 360 milligrams per day, and cumulative is around 720 milligrams. Now, the dose is definitely higher than the dose which was used in those observational studies. But before passing on the judgment, one should remember that these were only observational studies. They were not robust randomized controlled trials. Also, one doesn't know whether the steroids was given to the sickest of the patients, that is already who were more likely to die, or whether the steroids were the cause of mortality. It's like we do not know whether the egg came first or the chicken came first. So the baseline severity was not taken into consideration. Second point is that the mothers were not part of those studies. So we should continue to use antenatal corticosteroids in babies less than 34 weeks and consider case to case basis for babies who range from 34 to 36 weeks of gestation. Also, in one of the largest observational prospective cohort studies of around 1 lakh, it was seen that the mortality before hospital discharge in babies who were giving antenatal corticosteroids was no different in babies who were more than 31 weeks of gestation. Also, to prevent one death, the number needed to benefit at 24 weeks was 6, whereas at 34 weeks or more, it was around 800. Therefore, it must be given to all the babies less than 34 weeks, considering the beneficial effects, and beyond 34 weeks, one may consider on case to case basis. The other thing was magnesium sulfate, which is used antenatally for neuroprotection. Now, the concern about magnesium is that it may cause respiratory depression in mothers, because respiratory distress is the commonest symptom of COVID-19. But one should remember that magnesium has been used for decades as bronchodilator because of its effect on smooth muscles. It also decreases production of reactive oxygen species. Therefore, it may be beneficial in COVID-19 patients by causing dilatation of smooth muscular smooth muscle, as well as bronchodilation. Also, we know that cytokine storm and free radical injuries are the predominant modes of injury causing morbidity and mortality in COVID-19 patients. And magnesium, being an anti-free radical molecule, may be beneficial. It has no role as a tocolytic in COVID positive mothers, but one should always ensure that before giving magnesium, the mother should have a normal renal function, which can be easily monitored with the help of urine output. So one should, so the crux of this slide is that one should continue using magnesium sulfate in preterm neonates for less than 34 weeks for neuroprotection and decreasing the rate of cerebral palsy. Other controversies regarding delayed cord clamping. Again, from the past evidence, we know that it decreases mortality, decreases intraventricular hemorrhage. It also improves hemodynamic stability and improves iron stores. Now, what is the controversy is that delaying clamping of cord by 60 or more seconds may increase the risk of infection. Now, for a baby who has been inside the mother's womb for 9 months and has been sharing blood with the mother, whether these 60 seconds will cause any harm or not is still to be debated. But the data from centers who are still practicing delayed cord clamping and centers who have stopped delayed cord clamping in view of this COVID pandemic, There was no difference in morbidity and mortality when we compared it, although there is no head-to-head trial. Therefore, considering the vast benefits of delayed cord clamping and practically no risk, the risk, although there is a theoretical risk, but practically we haven't seen any problem in continuing with the delayed cord clamping. Therefore, one should continue to do delayed cord clamping in babies who do not require resuscitation for 60 seconds or more. Now, coming to the vertical infection, that is vertical transfer, in order to remove any ambiguity and provide a uniform definition, Shaw et al. In their editorial have given a definition of congenital infections for babies with clinical features as confirmed case if there is detection of virus in the umbilical blood or neonatal blood collected within the first 12 hours of life, or if there is demonstration of the virus in the amniotic fluid prior to the rupture of membranes. That is where testing is important immediately after the birth, preferably within 2 to 12 hours of life, and should not be delayed by more than 24 hours. In babies who do not have clinical features of infection in newborn, demonstration of virus in amniotic fluid does not confirm it to be a congenital infection. Now, there are various case reports, almost 10 case reports, which have given us enough evidence of vertical transmission of COVID-19, but I would like to enumerate one such case report here. It was a 34 weeks vaginal delivery with mother being COVID positive and was symptomatic. Baby had a slightly abnormal cord ABG at birth. Although there was no delayed cord clamping, no skin to skin contact, there was immediately separated from the mother and was bathed. But baby became symptomatic on day 2 of life, was positive for COVID at 24 and 48 hours of life. And when placenta was tested by electron microscopy and immunohistochemistry, there was demonstration of virus. Therefore, on this diagram on the right, you can see the demonstration of virus within the sensiti trophoblast when seen under electron microscopy. And you can see to the left the lymphocytic infiltrates showing features of phlebitis due to the viral infection. Other case report has been reported by Vivanti et al. From France and was published recently, in which they have demonstrated virus in amniotic fluid, placenta, as well as baby tested positive for virus immediately after birth. And this baby also had features of hypertonia, opisthotonus, and MRI showing bilateral glycosis, although at follow-up at 3 months, the baby had largely recovered and had very minimal neurological deficit. Now, recently there was one meta-analysis published on vertical transmission, which had around 402 mothers with 405 neonates. Out of the 330 babies who were tested within first 48 hours with the help of RT-PCR, 9 came out to be positive for COVID-19. Therefore, the vertical transmission in this meta-analysis was 16 per thousand newborns with a confidence interval of 3.4 to 73. Now, we know that there is a vertical transmission, but why is it rare when we compare it to other viruses like cytomegalo and more recently Zika virus? It's because of the receptor and the enzyme. The coronavirus requires ACE2 receptors and an enzyme called as TMP RSS2 to enter the cell and function. In this diagram, along the y-axis, we can see the various type of types of cells in the placenta as well as the fetal membranes. And along the y-axis, we can see the different type of receptors. Now, for coronavirus, we require ACE2 receptor and TMPRSS2 enzyme. As can be seen, both the enzyme and the receptor are almost absent in the placenta and the fetal membranes. Therefore, the vertical transmission is almost absent or negligible. Now, how does this virus enter the cell now? It is because the virus uses the alternative mechanism like BSG receptor and CTSL receptors to enter the cell and cause infection. However, one should remember that these alternative mechanisms of entering and infecting the cell are not as efficient as ACE2 and TMPRSS2. Therefore, vertical transmission, although is possible, it is rare when compared to other infections like CMV, which uses NRP2 receptors, which is abundantly present both in the placenta as well as the fetal membranes. So, conclusion regarding vertical transmission is that yes, it is possible, but the evidence is low. But what is now required is data from the first and second trimester infected mothers to know whether this virus is teratogenic or not, and whether it can lead to stillbirths, intrauterine deaths. That has to be still uncertain. Now, coming to the mode of delivery, we all know that cesarean section is associated with increased neonatal respiratory distress and need for respiratory support, especially when the cesarean section is done electively. This is because of the delayed clearance of the lung fluid. Therefore, one should remember that COVID-19 per se is not an indication for cesarean section. Only obstetric indication should prompt a clinician to do cesarean section, and only in mothers who are symptomatic with significant respiratory distress should be taken up for cesarean section. It has also been shown that cesarean section increases the ACE2 receptor in the lung and vascular smooth muscle cells, therefore may facilitate the entry of the virus into the cell and the infectivity. Second, other concern is regarding the breast milk. We all know that viruses can be secreted in the milk by paracellular passages. However, the secretion is increased when the mother is ill or is suffering from fever or infection. It is because of the opening of the tight junctions. Also, during feeding, there can be possible infections from droplets, skin to skin contact, breast pump, or infected milk containers. It has also been seen that coronavirus has been detected in breast milk in recent case reports. Now the evidence has shows that virus is heat sensitive, and whether the presence of DNA, which is detected with the RT-PCR, confirms the infectivity of the milk or not has to be seen. Now in the recent report, which was published in JAMA, a mother who was test whose milk was tested for coronavirus by RT-PCR, her milk tested positive between day 10 to day 13, but it was absent after day 14. That is, it tested positive only for 4 days when mother was symptomatic. Although this mother had a relapse, but the breast milk was negative for the virus. Now, why this virus is present intermittently? Was it because of the contamination? Because this mother was roomed in with another mother who was COVID positive, and whether the detection of genetic material confirms infectivity or not is still to be answered. Now, if at all virus is present in the milk, if we agree, although it is still far from truth, even if it is there, it can be destroyed by heating. That has been demonstrated in a recent study published in CMAG, where they tested 10 samples and heated it to 62.5 degrees Celsius for 30 minutes. And despite high viral loads, all the samples after heating for 30 minutes were negative for the virus, therefore demonstrating effectiveness of pasteurization. Coming to the symptomatology and associated lab findings, the symptoms can vary from lethargy, fever, feed intolerance, vomiting, diarrhea, cough is rare in neonates, and shock. The investigations which are seen in such neonates include leukocytosis with lymphocytopenia, thrombocytopenia, raised CPKMB, and abnormal liver function in the form of elevated AST. But these are non-specific markers. In Indian data, we have seen that these babies have high LDH, and the average LDH in these babies was around 1,000 international units. Coming to the management, the most common symptom of COVID-19 in units is respiratory distress. Therefore, knowing and doing airway management in an optimal way is very important. One should always consider cuffed endotracheal tubes and tracheostomal tubes to limit the aerosol spread. The most experienced person should handle the airway to limit the number of attempts. Also, one should use video laryngoscopy whenever possible for intubation because that increases the distance between the doctor and the patient and thereby decrease risk of infection. It also gives better visualization, therefore less risk of repeated attempts. One should avoid handbagging and if at all it's required, should reduce the duration to limit the aerosol spread. Always one should prefer inline suction compared to the open suctioning, and one should always discharge reusable airway equipment in plastic bags for proper decontamination and spreading the infection. The non-invasive respiratory support is the cornerstone of respiratory support in neonatology, and that holds true even in present era of COVID-19 pandemic. One should always prefer low flow rate and closed system. That is, CPAP should be preferred over HFNC, and when HFNC is used, it should be used with low flows. One should always prefer ventilator CPAP or bubble CPAP. This is because if the neonate deteriorates, he can be ventilated on the same machine with the same circuit without changing the circuits and thereby without increasing the risk of infection. One can also use the filter at the expiratory limb to limit the aerosol spread and spread the virus. One should always wear full PPE while caring for such babies to be safe. Now, the concern regarding filters is that they may increase respiratory resistance and work of breathing. In a recent study in which they tested three CPAP models on a lung model, they demonstrated that attaching filters only adds to minimal increase in respiratory resistance and very increased little of work of breathing. Therefore, adding filters is feasible and effective. This is the filter which is attached to the expiratory limb. The problem with the filters is that it does not eliminate the spread of aerosols. There is some leak at the nasal interface and as well as the mouth. Therefore, there can still be aerosol generation, although it will be less with the help of filter. Also, when we are using humidification, which is a norm in neonatology, these filters can get clogged and therefore they need to be changed as per the manufacturer guidelines. Now, this is an algorithm for respiratory support in a patient with COVID. Whenever a neonate has respiratory distress because of the COVID, he should be started on ventilator CPAP or NIV. If both are not available, HFNC can be used. It is not contraindicated, but low flows, usually within 6 liters, should be used. If there is a failure of CPAP, one can try NIV, and if there is failure of NIV, one can always try ventilation. One can even consider surfactant, even if the baby is not premature, because in COVID, it has been shown that the pathology of the lungs is similar to the hyaline membrane disease, and one may consider giving surfactant for for treating secondary surfactant deficiency. During extubation, such babies can be extubated to NIV, CPAP, and or hood box. Where the risk of reintubation is more, they should be started on NIV or CPAP, and one should always use hood box in compared to oxygen prongs because the risk of aerosol generation is more in oxygen prongs compared to hood box oxygen. For babies who fail ventilation, they can be started on HFO, and if there is failure of HFO, they can be given a trial of ECMO. Now, coming to the feeding protocol in babies who are more than 34 weeks, which are almost which have well developed immunity, they should be directly started on breastfeeds because there is proper sucking, swallowing coordination, and immune system starts developing by functioning by 34 weeks. Therefore, they can be started directly on breastfeeds. However, if the mother is symptomatic or the breastfeeding is not involved, they can be given pasteurized donor ABM and it should be preferred over formula feeding. However, during direct breastfeeding, one should always ensure that there is a face mask, preferably an anti-fave mask, but if it is not there, even a surgical mask will do. Washing of the breast, decontamination of the surfaces every 3 to 4 hourly, and distance of 2 meters when the mother is not feeding the child. Similarly, less than 34 weeks, because there can be issues with sucking, swallowing, and they are also immune immature. Pasteurized express milk can be given so that whatever theoretical risk of getting the virus is there, it is eliminated. Now, coming to the tests, there's a lot of confusion regarding the tests. One should remember that there are two tests. One is the diagnostic test and another is the antibody test. The diagnostic tests includes RT-PCR, that is the molecular test, and the antigen test. They are the tests which are done for confirming the infection and they are used for the current infection. Antibodies tests are not a gold standard for confirming the infection. They are only done on community basis to check the status, whether the person has been infected in the past or not. They cannot be used for acute infection. It is because the antibodies take at least 1 to 2 weeks to develop. Now, the molecular and tests is a gold standard, and once it is positive or negative, it does not need a reconfirmation by any other test. Antigen test, although it is a diagnostic test, if it is negative, it has to be followed up with RT-PCR to label the patient as negative. However, if antigen test is positive, one can label the patient as COVID positive. The best thing about antibody test is that it does not require a throat or a nasal swab. Therefore, the risk of infection, risk of spread to the healthcare workers is least because here the blood is used for testing. Also, antigen test is rapid, can be result can be available within an hour or so, compared to molecular tests which may take 1 to 2 days or up to week in some places where the resources are limited. Antibody tests on the other hand take usually 1 to 3 days. Now, there are certain factors which affect RT-PCR. These include technique, site, stage of the disease. RT-PCR is more likely to be positive in acute stage of the disease. It also depends on the multiplication and clearance of the virus, and also whether a single gene or multiple gene targets are being targeted. Now, depending on the site of sampling, bronchoalveolar lavage has the highest sensitivity of 93%. Therefore, for any patient who is intubated, bronchoalveolar lavage sample is ideal. And remember, throat swab has the least sensitivity of 32%. Other testing errors which one should always keep in mind is that swab should always be collected from nasopharynx, and one should always avoid contamination during collection, analysis, transport, and analysis. One should always remember that during transportation, they have to be kept at a proper temperature according to the manufacturer guidelines. And if we do not maintain the temperature, there is a possibility of getting a false negative test. Also, the chemicals which are used to extract the virus genetic material, the quality has to be assured. And remember that RT-PCR has a low sensitivity of around 70%. Now, before explaining about the tests further, I would like you to answer two simple questions. Question one is that a neonatal fellow develops cough, intermittent fever, and malaise. Therefore, on day two, because of working in a hospital, being exposed to COVID, and having symptoms such as COVID, he does a COVID-19 test, which turns out to be negative. However, he continues with cough and low-grade fever, but he feels well enough to return to work. What should he do? Should he go back to the hospital? Should he isolate for 14 days? Or should he do repeat testing? Or should do whatever his consultant says? Now, before answering these questions, let us see one more example. A 7 hours old neonate born at 28 weeks who did not receive steroid had RD since birth. Mother did not have any fever, no exposure to COVID, no travel history, presented with preterm labor, and was tested COVID negative. X-ray of the neonate was suggestive of ground glass appearance. Neonate was placed in holding area, and subsequently his RD worsens and he gets shifted to NIV. Initial nasopharyngeal swab was negative at 24 hours. Now, should this baby continue to remain in COVID ward, or should he be shifted to non-COVID NICU, or should we intubate and do bronchial lavage, or should it be treated as COVID-19, or none is correct? Now, I will not give answer to these questions because I want you to develop few concepts and then anybody can answer these questions. Now, there is something called Bayes theorem. Now, before knowing a sensitivity to the test, how do we know the sensitivity of the test? If there is a certain new test for particular infection, for example, we want to test sensitivity to the CRP, it has to be compared with the gold standard like blood culture, for example, in case of sepsis. But for COVID-19, there is no gold standard. So how did we get this sensitivity of 70%? It was obtained by doing RT-PCR repeatedly in patients and seeing the positivity rate. It was also based on history and examination. Therefore, whatever sensitivity has been reported, 70%, it may not be even that much. It may be much lower than that. Now in this diagram, we can see a leaf plot. The x-axis shows the pre-test probability and the y-axis shows the post-test probability. Now before going further, we need to know what is Bayes theorem. Bayes theorem tells us the probability of an event by knowing certain facts about the event beforehand. That is based on the pre-test probability, we can test, and based on the pre-test probability and the test results, we can tell the possibility of infection in an individual. Now in case A, where the resident worked in a hospital, had COVID symptoms, the pre-test probability will be very high, to around 90%. Now in this plot, the lower limb is for test negative and the upper limb is for test positive. Now if pre-test probability, for example, in our first question is very high, that is around 90%, despite the test being negative, there is still a 75% chance of him being COVID positive. If we repeat a test, the probability comes down from 75 to 45%. Therefore, even if test is negative, but there are symptoms, there's a history of contact, one should always consider possibility of COVID-19 despite a negative test. In second case, we had a preterm 28 weeker who did not had steroid covered, had features typical of respiratory distress syndrome, tested negative. So in second case, we had an alternative diagnosis of RDS and all his features can be explained by RDS. Therefore, pretest probability is very low of around 50%. Therefore, if he tests negative, there is still 25% chance of him being COVID positive. And if we repeat the test, this probability drops down to 10%, which is acceptable. So for an individual who has symptoms, history, close contact, even two tests does not eliminate the possibility of COVID patients. But for a patient in whom we have a possible alternate diagnosis, repeating a test almost eliminates the possibility. And if both the tests are negative, it almost eliminates the possibility of having COVID-19. Now, the good thing about these tests is that if they are positive, for example, in case 1 or case 2, in case 1 or case 2, if they are positive, they are almost confirmatory that the patient is suffering from the disease. Now, when should we test? If a baby is born to a positive mother, if he is symptomatic or asymptomatic, the test needs to be done immediately after birth. Why? Because to know whether there is vertical transmission or not. If we delay it, we cannot rule out horizontal transmission. In case of symptomatic, if the day one test is positive, it needs to be followed up at 48 hours because sometimes we may get a false positive because of the contamination of blood and maternal secretions. If the repeat test is also positive, then we may repeat a test before discharge to demonstrate a negative PCR. However, one should remember that sometimes the PCR can remain positive for months despite baby being non-infective and cured. In asymptomatic, once we have done it 2 to 24 of life, we can If he remains asymptomatic, we can do test anytime, anywhere between day 5 and 14, because that is the period when the yield is highest. Or if he becomes symptomatic, we can do it earlier also. So the conclusion regarding test is that it should be done immediately after birth, preferably within 12 hours and not more after 24 hours. And positive RT-PCR is good to rule in COVID-19. But remember, a negative swab test cannot be definitive for ruling out COVID-19. Now, when to discharge? For more than 34 weeks, if the babies are asymptomatic, second sample is negative, he is asymptomatic for 48 to 72 hours, he receives 0 dose of vaccination, he can be discharged. Follow-up should be telephonically or preferably with the help of video call, done every weekly, and subsequently in-person follow-up can be done at 6 weeks, 10 weeks, 14 weeks, or if he becomes symptomatic. These coincide as these 6, 10, 14 weeks is the time for vaccination. Therefore, both can be clubbed together. In babies who are less than 34 weeks, once they test negative, they are on 4 feeds. There is adequate weight gain for 3 or more days. The screening has been done and it's normal. They can be discharged and followed up twice weekly till they are term equivalent, and subsequently follow-up can be at 3 to 4 weeks of life for ROP, and subsequent follow-up can be similar to term baby or if they become symptomatic. If the baby is symptomatic or RT-PCR is positive, so one should always demonstrate negative RT-PCR. He should be symptom-free, and then follow-up is similar to those who are asymptomatic. For less than 34 weeks, it is important to establish feeding, demonstrate a good weight gain, and complete screening before discharge. Thank you. I wish you all a safe stay and wish you all good health and positivity all around. Thank you.